So, good morning, ladies and gentlemen. Today, we are going to have a very, very nice list of a lot of cases you're going to see. So, we are going to start with a simple case of septal correction. And this is done by the Royal Pearl technique. So, what is Royal Pearl technique of septal correction? I think it has been published by Dr. Uday Chanukya. You can go and refer to it. And I'm going to show you step by step how we do a septal correction by our technique. And after that, we have, of course, an adenotonsil. We have an extrusion of a gold implant because I will tell you the reasons. And then we have one of the finest cases of ossifying fibroma, which has been operated around 5-6 times before, and it's going inside the brain. So we'll be having a beautiful list today. You'll be seeing all that now. And of course, we have one pituitary. So that also I'll try to live. Okay, so first is the septal correction. So as we know, previously we used to say septoplasty, SMR, all that. So this is all in the pre-endoscopic era. So now we know that all that is not followed, and we just have a term called septal correction. So what is this? We actually try to correct only the deformity. Whatever is the deformity, we try to correct it. Apart from that, we just try to leave behind the other parts of the septum which are straight. So it's neither an SMR nor a septoplasty. And in our technique, we have modified the incision, where to make the incision, and how to create, do a septal surgery without a tear. So these are all the highlights which you will be seeing in this video. So we are going to start the case in another 5 minutes. So stay with us. I'm just going to wash up and come back. very carefully. Wait, wait, wait. Okay, on. My mic on. Huh? Okay, so what we are going to do, if you look at the scan, this patient has got bilateral maxillary sinusitis. So what we are going to do is do a MMA on both sides and a head end elevation. You see, when you pack, see here, this is the way you pack. When you keep it like this, your head end elevation. See, the instrument should go below. 1, 2, 3, 4, 5, 6, 7, 8. At no point was the instrument tip not visible. It was always visible. That is how you pack. And we use a gauze which is soaked in 1 in 1000 adrenaline. Okay. Now you see, I'm not packing, seeing it. I'm just packing from outside. Now this is a deviated side. You can see the deviation there very clearly. And there's a little anterior deviation too. And this patient has bilateral maxillary sinusitis. Okay. So what I'm going to do, get me a syringe with antibiotic and steroid. Or gentamicin amicacin with the steroid, decadron. Okay. Kudukriya. So, okay. Having done that, you see how it's decongested very well. You understand? Now, what I'm going to do is to make a little bit bigger. This is bigger, slightly bigger. Now, the first step in endoscopic sinus surgery is this. Give me elevator. So always, 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 if you see all my cases, see here, the instrument goes in the first, and then the scope follows it. 1, 2, 1, 2, 3, 4, and then you keep your belly of your instrument like this. See that? And you lateralize the inferior turbinate. This will be my first step. But try not to produce bleeding when doing this. Okay? And then try not to medialize the middle turbinate. If you medialize the middle turbinate, you create a green stick fracture here. So you will destabilize the middle turbinate. So suppose you have a big middle turbinate, how do you operate in this small narrow area? This is one big challenge. So what we do is we keep a small gauze piece which is soaked in adrenaline, soak it in adrenaline. See here, this is the technique which we follow. Is it soaked? Now see here, and this is twofold. You see here, I go inside, see my elbow. Hey, see my elbow. See, I go like this, and then see here now, 1, 2, 3. And then I go towards the sphenopalatine foramen. You understand? So this is soaked in adrenaline. So I'm just trying to squeeze that artery. You get my point? When I what happens now? See the middle turbinate moving medially. When I do that, see what happens to the middle turbinate. So there are two actions of this. So what I do is I cause hemostasis by doing this, as well as I'm moving the middle turbinate medially without fracturing it. Just a gentle motion. You understand or not? See that? You see that clearly. So what I'm trying to do is to create a small pack at the level of the sphenopalatine foramen. You understand? So what happens now? It slightly moves. Of course, not much, but gently moves. See that? Now I'm trying to force it inside. Now I'm able to see the bulla. Can you see here? Now that's the area where there is the sphenopalatine foramen, right? Have you seen the sphenopalatine foramen, my dear Francisca? Have you seen it? Have you seen it? Okay. So that means you know that I'm placing it right on the level of the sphenopalatine foramen. By doing that, you will cause hemostasis. You understand? Now what I do is I take my backbiter. So you see how gently it's moved out, not fully, but a little gently it's moved out. Now you see here, I'm just going, see my elbow and see how, see, never take it like this. I see some of the Ostram's reverse punch, side punch. So they have that side like this. I don't like that. You have to direct it upwards. See here. Upwards, and then your elbow moves. See here. And then gently go here. And then move gently the middle turbinate. Go inside the hiatus similaris inferioris. And then gently elevate it. Elevate it. And then gently bite it. Get my point or not? So this is how you do it. Okay, that's it. You get my point? The second step always is the ball probe. Okay, what do I do with the ball probe? Direct it towards the ipsilateral outer canthus and gently move the upper part of that uncinate process. Okay, and then what you do, take the debrider. So this is step number 3 in FES, middle metal antrostomy. You understand? So here we are. I'm taking this debrider directed laterally, and as I do here, you see here, see the movement of the debrider. It's this way. See here, it's this way. It's this way. You understand? So it is almost, going sagittally. So here we don't need to remove till the level of the frontal recess because it's not involved. So I'm just going to transect it only till the middle. Now this is the area where you have the natural ostium of the maxillary sinus. Can you see here? That's the infundibulum. Can you see that infundibulum here? Little edematous, but you can see that very clear. Of course, if I use an angle telescope, you'll see that. But I don't generally use that. Give me a ball probe. And now what I do, I know exactly where the natural ostium is. So I go right there. See here. This is the level of the natural ostium. See the bubble. It's called the bubble sign of Stamberger. This is the bubble sign of Stamberger. Okay. So if there's a bubble coming out, it's the bubble. So I can just pack it again. Pudi. Give me one more pack. So I want to show you what is called the hanging technique. Hanging technique. All these are not published, but then this is how I teach my students. Okay. So you see here, I'm just packing. Just packing just to get a little hemostasis. Get my point? Now, there are 2 ways of dissecting the middle, that is the natural ostium. One is what is called the submucous dissection. So I will teach you in a different case. This I'm not going to do this. There are 2 ways. One is called the submucous dissection. Second is the hanging technique. I'm going to show you the hanging technique in this case. I show you how to do that. That's the simplest way to do the MMA, middle meatal antrostomy. You understand? So see that. Now see that's the horizontal part of the uncinate process. Now what I will do is, you can see here, this is not the one actually. This is a frontal ball probe you're giving me for the maxillary sinus. You see here, this is the natural ostium here. You can see that. And then you go, see here, I'll show you the movement. The movement is like this. Go inside, move it vertically downwards and backwards. Like this, like you hang on the horizontal part of the uncinate process. See here. Now I go again, I identify, I go down. See, I tilt it downwards, not upwards. Then you will go into the orbit. You go downwards, move it downwards and backwards. See that? Can you see that clearly or not? This is what is called the, what is that? Called the hanging technique. You understand? So that, see that? Can you see that? Can you see a small polypodal tissue inside? Can you see here? That's just a retention cyst. We'll take that out later. I'm now going to take that with a RAD 12 debrider blade. So that's all finished. It takes hardly a few seconds for you to perform the middle medullary antrostomy. So by the hanging technique. Of course, I'll teach you also the submucous dissection technique. Now you see, that's a RAD 12 debrider blade. You see here. What you do with this is, hey, block. See here. Now I'm going to take off that bone. That's the horizontal part of the onset process. Can you see that, Vishal? See here. That's the horizontal part of the onset process bone. See that? Can you see that? So that's the bone. I will also talk about the anatomy of that bone later. Now I just want to take this out. Come on, come on, come on. Don't delay me. I'm getting irritated. Now you see here. Now you see how I'm taking my சரியா கனெக்ட் பண்ணி கொடுறீ என்னடி ஆச்சு உனக்கு ஏய் நீ வேணா வாட்ச் பண்றியா see here now you hold it like this upwards not sideways upwards and then you keep it like this and then see how I'm taking it inside. That's how you take it inside and then the movement is I'm going to take off the gauze piece because I'm scared that this gauze piece will come into my debrider blade. See, every movement should be delicate. It should be like a piece of art. I always insist that. See that? Now, see that's a bone. Can you see that bone there, all of you? This debrider will eat away the bone. Not an issue. See what is Vishal doing? He'll irrigate. He'll irrigate. You understand? So that's it. I've done a wide middle medullary antrostomy. And now you see that there's a small polyp there, right? Okay, I'm going to use my RAD 60 debrider blade now. I'm just going to see these polyps are actually retention cysts. They're called RCTs. You don't need to excise it completely. It will not turn into an antroconal polyp. What's the difference between both? You see here, if it's an RCT, you will have yellowish fluid inside. Okay, let us see. Let us check whether I'm right or wrong. See here, I go closer. So it doesn't have, then it's a polyp. So if you have a cyst, then it is, you will have an yellowish fluid. Now, if you have a polyp like this, you have to remove it completely. So then I use my 70-degree telescope. So we have only two scopes which we use. We don't use the 30, we don't use the 45, we use the 0 and the 70. So I use my 70-degree telescope to visualize the origin of that polyp. You understand? Now, see how I introduce. You should not introduce it straight. You keep it like this and then go like this. So these are all the nuances you should understand. See now, you can see that's the attachment of the polyp. Can you see that clearly? In the posterior wall, So I have to debride that or else it will come back. Whenever you find a polyp, so what's the difference between a cyst and a polyp? You will have histamine, the yellowish fluid inside a cyst. Usually it's from the floor, arises from the floor. And when you puncture it, that is a treatment. It's marsupialization. Whereas a polyp, if you debride it, you will not get that fluid. It will be solid. And you have the difference is you have to remove it completely from its origin. You understand? So this is the difference. You see how I'm move. See my body position. It's at 90 degree to the, see here, 1, 2, 3, 4, 5. This is the RAD 60 debrider blade. See that? Now I'm right inside. A little difficult. See that? I've removed it now. Can you see that clearly? That's it. Finished. See, Vishal is doing a beautiful job. Whenever I'm getting fog, he is now. So that's it. That's the end of that. Okay. Now what I do again is 0 degree. I use angle telescopes very small time. I don't use it too much. The reason is Your orientation, unless you are very experienced, your orientation becomes bad. Now I'm going to show you suction straight. Now you see here, I'm going to suck. Hey. Okay, now that's it. I don't even need to pack. There's no bleeding there. That's the area of the sphenopalatine foramen here. And it's been done very well. I don't need to do anything. Okay, right. Now I just want to show you only one thing. Check the freers. I want to check the mobility of the middle turbinate, whether I have destabilized it. See that? It's not been destabilized. If it's destabilized, it will move badly. See here. I have not destabilized the middle turbinate, so it will not lateralize. If you had pressed it here, then there's a chance that it will lateralize. Here, it will not lateralize. So this is very important. You understand? Now I'll go for the next step, the septal correction. You have to cut the hair and give it to me. This is not the way to do it. So always cut the vibrissae, infiltration. So I'm going to show you the technique of my septal correction. It's not called septoplasty. It's not called SMR. See how I'm holding my needle. Very, very important. Not the usual way. I hold it like this. Okay. And how do I do it? You see here. I give the infiltrate. This is saline, just saline. There's no xylocaine. There's no cocaine, nothing. And you go inferiorly and then make the infiltration. You understand clearly why you go inferiorly? Because you don't want the scope to get fogged. Because of that, you will have a little bleeding, you'll get fogged. Don't give too many infiltrations. The second point. Same way, the other side infiltration should be in a different place than the first place, because I don't want to create a weak area in both the sides of the septum. You understand? So here I'm giving a little posteriorly, but again inferiorly. See how beautifully I'm elevating that. See, this itself will cause elevation. It's called hydrodissection. You understand? It is called Francisca. Yes. Yes. I need that you repeat it so that you remember it. Now, where do I make the incision? This is very, very, very important. Many people make an incision just posterior to the squamo-mucosal junction. But what I do is I make it right on the epithelium. Why? Because the epithelium will not tear. So I make it, so I'm making it right on the epithelium, that is on the squamous layer. You understand? It's vertical. You don't make it like a C. You understand? So that's the difference between, so this is the first part of my technique, which I devise, and I always make the incision on the deviated side. So I'm using a Cortels elevator here, and you see this is a three-handed technique. See what Vishal is doing now. So he is actually putting the suction inside, and I'm slowly suctioning. So this is what is called the three-handed technique of septal correction, so that you exactly see what you're doing. See what I'm doing now. I got it to the layer very, very fast. You get my point? So that's it, finished. Once you do that, so that's the deviated part, right? Can you see that clearly now, all of you? Can you see or not? Yeah, now see that. Now, if you have a V-shaped deviation, take it off. So this is like here, it goes like here, but sometimes you can have like this, V-shaped. If you have a V-shaped deviation, don't elevate beyond the V. That is, only the one limb of the V should elevate. You understand? So what I'm going to do now, see how beautifully Vishal is helping me. I'm pressing this septum and I'm trying to actually elevate that flap. But what I'm going to do now is to create what is called the septal window. So this is the next step, which I have designed. It's so easy to do that. Hold it like this, Vishal. Is it not working? You're holding it. Don't hold it. Hold. Vishal, hold it. Oh, nice. So I create a small window called the, so I leave behind the caudal strut and I create a small window. I slice the septum here. I don't incise, I slice. Please understand there's a lot of difference between slicing and incising. So this is slicing the septum. Can you understand what I'm trying to tell? Now what I do is I go on to the other side and then gently elevate this side without trying to cause a tear at all. That is the submucoperichondrial plane. You understand? So once I do that, I have now just elevated a little bit of that septum. You understand? Now what I'm going to do now is scissors. I'm going to remove that part of the septum like a small window. Why do I want to do a septal window? Why? Because when you do it endoscopically, you have a lot of space now to work. Elevator. You have a lot of space to work. Your scope will not get fogged, and don't press it too much. Now see what has happened now. I see the scope is 4 millimeters, and I need space for this 4 millimeters as well as the instrument to work. You understand? So this is, see that window which I created, small window of the septum. You remove that. And now what happens is that you open up the whole area. You see how, see the kind of exposure now I get. You get my point? Now, the first step you have to do is always secure the opposite side flap. You should not have a tear, any tear here, because this I call is the platinum side of the flap. You should not create just, and you see the movement, it's not up down, it's like elevation. Come this side, my dear friend. Little, hey, Vishal, you should stand this side, my dear. Hey, be careful. Good. Now, good. You see how beautifully we are able to visualize and elevate it? This is a beauty. Believe me, you have, hey, take it off, take your septum off. So I made sure that the opposite side septum is not torn, because my primary concern in a massive deviation is not produce a perforation. So I don't want a perforation, and for that, the single most criteria is not to have a tear on both sides. So I don't have a tear on this side. I'm safe now. Now I can do whatever I want with this side. You understand the point, please? Yes. Now you see here, I have now, see this septal window is giving me so much of leverage. I'm able to see so much inside, or else it's going to be very difficult for me to elevate with the part of the, see how much of space I have now to see this. You get my point? Now, what I will do is, now I've elevated this with the suction itself. You can use a suction elevator if you want. See, that's the sphenoid sinus. Can you see the anterior wall of the sphenoid sinus here? I've gone right till there. So this part of the flap will be very safe. You understand? So now I go to this side. So what is going to happen on this side? Let's see. Okay, now here we are. This patient complains of nasal obstruction because of septal deviation. Now you see here, I'm now trying to elevate here. Don't be in a hurry to elevate all that area which is deviated. Go step by step. Now, as I go inside, see that how I'm trying to elevate the flap. A little bleeding is there, it's okay. So what you have to do is, see, the idea is not only elevation, but forcing it towards the other side. Now I have so much of space here, the leverage is so much. So it is not just elevation. As we elevate, you force it towards the opposite side. You understand? That's very, 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 very important. Now see here, that's the upper part of the septum. Give me a, now, never use, not this. Never use a lux forceps. Use always a scissors. So you have to do sharp dissections. You cannot twist it. See that now, what I'm trying to do. Can you see that? What I'm trying to do? I'm trying to cut it. I'm not trying to pull it. If you pull it, there's a chance of a CSF leak, because you will have, I've seen people producing septal meningoceles. Now, having done that now, okay, having done that now, I got my, you get man. Now comes the difficult part. Now you see here, what has happened now is this is the cartilage. You understand this is the cartilage. And that cartilage has got dislocated from the bone. Can you see that? It's sitting right there. Hold this, man. I'll show elevator. See here. No, hold it here, my dear friend. See, this cartilage has got dislocated from this bone. That's why there's a deviation. So what you do is don't elevate here. Elevate here. You understand? So elevate towards the cartilage. But better is, see, that's the maxillary spine. See now. Now, never try to remove that. If you remove that, what happens is that you will have a tear. So what I'm going to do now is you create an osteotomy here. I will create an osteotomy here and then push it that side. So this is how we have devised our technique. Now give me a marathon gooch. Always, whenever you want to remove a deviated side, create two osteotomies. Superior osteotomy, inferior osteotomy, and then push it. That's it. Here it's anchored below. That's why if you try to elevate that, you're going to get a tear here. Good. Now see what I do? No. Tuck, tuck. Tuck, tuck. Tuck, tuck. Tuck, tuck. See that? Now I'm creating see, that's the superior osteotomy and that's the inferior osteotomy. Can you see that now? Clearly. Now what I will do is I will not elevate the cartilaginous part. I will elevate the bony part now. See here. See that? That's the bony part. Can you see that clearly? So what has happened is I'm getting a flap here. I'm getting a flap here. Can you see that? Very clearly. Can you see that or not? See, that's it. Finished. Once I do that, that's it. This is so sweet and simple. I love it. So in even a gross deviation, you don't produce a tear. Suction boot. So you have a flap here and you have a flap here. Can you see that clearly? Now what I'm going to do is to elevate that now here. Elevator. Now here we are. See here. Now take this and elevate it like this. That's the bony part which is nicely deviated like a butterfly. Now I'm coming to the cartilaginous part. See that? See, there's no tear at all. Absolutely no tear. Can you see that, Vishal? See, these are all the nuances. Everybody does septum. You should not create a tear. That is your idea when you go from Royal Pearl. Okay, because you're royal. What, man? Yashoda. Gently take this off. See that? That is the deviated part. Okay. Right. Now what I do is I want to assess the septum. Hold the suction now. Pinch the suction. I'll see that completely. The deviation is completely gone. Completely gone. See, but you see how thin the septum was, and we elevated it without a tear. Can you see that? Even the line there. So that's the whole point. You understand? Now, having done that, you have also maxillary sinusitis on this side also. Give me elevator, big elevator. And I'm going to finish another 3-4 minutes. Get ready. So the same thing I do here. And then give me a gauze piece now, please. Give me a small pack. See, this is a very, very solid middle turbinate. You don't want to. Never try to medialize a middle turbinate. I've seen so many surgeons. they'll do like that. I hate it. I hate it. You're creating a fracture of the middle turbinate. You understand? Don't create a fracture of a middle turbinate. This is the trick, not to do it. You see here. What is the trick? What? Yes, the trick is to keep the gauze piece in the sphenoparatine area. Okay, not in the foramen, the area of the sphenoparatine foramen. See that now? You see that? Now, once you do that, you see how it's slowly getting medialized. But of course, not by a fracture, but by gentle traction. That's all. Okay, right. Now what I'm going to do is I'm going to use my BHATIA. Do you understand the concept, Yashoda? BHATIA. See, again, don't take it like this. See your elbow, arm position. Go like this towards the ipsilateral outer canthus. 1, 2, 3, 4. And you go, gently push the middle turbinate and go inside. You have to see the hiatus semilaris inferioris. Then you have to cut. Okay. You see that? You have to go till the level of the maxillary line. This is the maxillary line. You understand? Now what you do, I'm going to show you another technique in this case, which is called the submucous dissection. That side I showed you the hanging technique. Hey, where is the other knife, ma? So what we do is we take off this mucosa medial to the horizontal part of the uncinate process. So give me a rat-12 debrider plate. So I'm going to show you this technique. It's again a beautiful technique. I'm going to show you that. Quick. Now you see here, again, hold it upwards, go like this. And then what I do is I'm going to take off. See, as I take off the mucosa, what do you see? You're seeing the bone. You see or not? This is what is called submucous dissection of the uncinate process. See that? You will always have a U-shaped attachment. See, that's a U-shaped attachment. See that? See that is the U here. That is the second limb of the U here, and that's the first limb of the U. So where does it get attached? See here. See. Beautifully seen. Beautifully seen. It's always like this. Always like this. Give me the ball probe now. So I'm just going to take. I'm going to take that horizontal part of the uncinate. This is the horizontal part of the uncinate process. Now I go down and I gently take that horizontal part by elevating the, see the bubble coming out. So, but I'm not bothered about the mucosa on the other side. I'm just wanting to take off. It's a different instrument. The problem is she's not giving that instrument to me. See the natural ostium. You see that? Now the idea is, see, this instrument is not good. The problem is she's saving that for the next case. That instrument has been saved for the next case. Anyway, fine, no problem. So always open the natural ostium. You understand? That is the concept. If you open up the axillary ostium, it's called, what is it called? Francisca. What? Stupid.
It's not possible.
It's called missed ostial syndrome. It's called MOS. Okay, it's called, you miss the ostium. It's called missed ostial syndrome. This is very common. Many people just create an opening in the maxillary sinus, but they open the axillary ostium. See, I'm eating off that bone, the horizontal part of the uncinate process. See that? I'm just trying to see what is there in the maxillary sinus. There is nothing there. I don't have to do anything. Anyway, it showed sinusitis. It's okay. That's it. Finished. So I have done bilateral middle medullarostomy, and I have done a septal correction. I don't have to pack it, but for the sake of the septum, I am just going to pack a little bit with, எதுமா புரியல. Give. Now, this is something which we do in some cases, which patient complains of sinusoid, sinus problem. But of course, in this case, it's a little, not polypoidal. But if it's, then this is, you see here, this is a little bit of antibiotic with steroid. Give me a Blexley. So what I do is, this is an antibiotic with steroid, and I just instill it inside the maxillary sinus. You see here. You see that? Thank you very much. Did you learn something? How was it?
Kind of the
Yes, because Alberto is here. Yeah, he liked this technique very much. Okay, so that's it. I've finished the first case. The next case is adenotonsil, and then I'll be doing extrusion of a gold implant, and then we'll be doing a huge ossifying fibroma. So what is the antibiotic I instilled? I instilled amikacin and decadron. So that you put in every case, you will have fantastic results. Fantastic results. So try to instill that in all your Francisco. So you'll be live. Maybe Alberto is seeing you. She's Dr. Remove your mask. So this is Dr. Francisco from Italy. Yeah, she's come for a training program here. Yeah. Okay, so I hope you enjoyed the surgery. I'm sure that some of you would have learned some new points. Oh, Amit is there. Amit Patidar. Yeah, hi, Amit. A very, very nice friend of mine, Amit. Dr. Rupali is there. Good. Dr. Gupta, MK Gupta. Hello. You want to talk? You want to talk about this technique, Dr. Gupta? You can unmute yourself.
Hello.
Yeah.
Good noon, sir.
Hello. Good afternoon. How are you?
Good morning, sir. Fine, sir.
Yeah.
It was very fantastic technique, sir, for spur removal.
Yeah. This
never
is
never seen before, sir.
yeah, we published this, and yeah, even in a gross spur, you don't get a tear. So it is very useful when you raise a Haddad flap. When you raise a Haddad flap, it's very good, because in cases where you want the flap for reconstruction, then this technique will be very good.
Yes, sir.
We have Dr. Shyam here. Let's see what Professor Shyam is, my very close brother from Hyderabad. Thank you, Dr. Shyam, for being there. You have any
Janaki, you don't remove posterior frontal in all the cases?
Posterior fontanelle.
Yeah.
What is it? What is your question?
MMA, posterior
if there is a axillary ostium in the posterior fontanelle, we combine it, or else we don't.
Okay.
So that is called a type 2, type 3 MMA. It is not required in case of this case of sinusitis. I can show you the scan. Put the scan. You don't require that. So a type 3 is done for fungal sinusitis, or if there is an axillary ostium, you connect it. Nice question.
And if the sinus is laterally placed, is there any other technique to enter into the maxillary sinus?
If the sinus is, for example, you have what is called the 6 sinus syndrome. BHATIA. So I will, so the technique is the same. The technique is the same, but you have to do the hanging technique. And the problem is, if in a 6-sinus syndrome, the orbit is very low. You might have enophthalmos. So be very careful when you enter it, and you have to go right below. Don't go above. If you go above, you'll enter into the orbit. So that is a technique. Nice
which
question.
condition-
6-sinus
in which-
syndrome, 3 types you have: type 1, type 2, and type 3. And yeah, nice. Thank you,
In
sir,
which
for joining.
condition you remove, in which condition you remove mucosa of the maxillary sinus?
We don't remove the mucosa. That is called nasalization of maxillary sinus. It's called nasalization. If it is going to be a chronic recalcitrant sinusitis, like for example, you have done 4 times, again and again, you have polyposis, you have type 3 polyposis, then we will remove the mucosa. Generally, if you do that, what happens is that you develop a lot of retention cysts. So the mucociliary action is not there, so you'll have retention and you'll have dumping syndrome. It's called the dumping syndrome. Try not to remove it as much as possible, but if you're not able to manage it, then finally you can do that. Again, a nice question. That is the problem with the Caldo-Luck. In the Caldo-Luck, what happened was we removed all the mucosa, patient developed a lot of maxillary cysts because there's no mucociliary beat. You can see the scan here. I don't know if you can see that. I'm just putting that for you. Yeah, you can see that this patient had a gross septal deviation, a septal spur, and also maxillary polyp here. You can see that. So I thought it was a retention cyst. So as I discussed, how do you differentiate between a retention cyst and a polyp? So I told you that also. I think it's very clear. Okay, so anybody else who wants to talk? Rupali, you want to talk?
No, sir. Actually, I joined late, but I saw the surgery. Wonderful as usual.
Thank you. So we have a lot of cases. Don't miss the last case. The last case is phenomenal case. It's one of the most thrilling cases you will ever see in rhinology. Anyway, thank you very much. And I will come back to you with the same. I will send us a different link and you can join in that. And that will be